So good evening. We would like to welcome everyone to this year's Thyroid Cancer Awareness Month live webinar hosted by the American Association of Endocrine Surgeons, otherwise known as the AAES, in partnership with the American Thyroid Association, known as the ATA, and ThyCa, the Thyroid Cancer Survivors Association. I'm one of tonight's co-moderators. My name is Vikram Krishnamurthy, and I'm an endocrine surgeon at Cleveland Clinic.
Hi, my name is Dhaval Patel, and I'm the other co-moderator tonight. We have assembled an expert panel to answer common questions about thyroid cancer and surgery. We would like to thank ThyCa for providing us with the questions most commonly asked by its membership. In addition, we'll be taking live questions from the audience. Simply type your questions into the comment section of the Facebook live stream.
So we will start by introducing our panelists in alphabetical order, who will tell you a little bit about themselves. And so first I would like to introduce Dr. Avital Harari.
Hi everybody, thanks for joining us, and thanks to the ATA and AAES for putting this together. I'm an associate professor of endocrine surgery at the University of California, Los Angeles, UCLA. I'm also the Internet and Social Media Committee's chairperson at the American Thyroid Association. Just a little bit about my research interests. I'm interested in risk factors for advanced thyroid cancers, especially those that we don't know yet about, environmental risk factors, for example. Nice to see you all.
Great, thank you. Next, I would like to introduce Dr. Angela Leung.
Hi everyone, it's nice to join you all here too. Thanks so much for the meeting organizers for having us. I am Angela Leung. I am an endocrinologist, so a medical person, and I have research and clinical interests in managing thyroid disease of all types, specifically maybe thyroid nodules, thyroid cancer in pregnancy and postpartum, sort of those areas that deal with women of childbearing age.
Great, thank you. Next, I'd like to introduce Dr. Carrie Lubitz.
Thank you, Vikram. Thanks so much for having me. My name is Carrie Lubitz. I'm an endocrine surgeon at Massachusetts General Hospital. I have research interests, some of which were sponsored by ThyCa, so thank you all, and interest in using mathematical modeling to actually simulate the thyroid cancer population, as well as health-related quality of life measurement in the thyroid cancer population. Thanks for having me, and I'm happy to answer any of your questions.
Great, thank you. And then next up, Dr. Kepal Patel.
Hi everybody, thank you very much once again for joining us, and I want to thank the AES and the ATA and the ThyCa organization for really putting this webinar together. I am an endocrine surgeon at New York University Langone Medical Center. I'm the director of endocrine surgery there. And my research interests really include, molecular pathogenesis of thyroid cancer, and I've been doing some work also on looking at inflammation and thyroid cancer. So once again, I'm honored to be here and look forward to this hour.
And last but not least, Dr. Linwah.
Hi, thanks so much, and I'm excited to be here. I want to thank, of course, AES, ATA, and ThyCa, and of course, Vikram and Dhaval for putting everything together. My name is Linwah. I'm an endocrine surgeon here at UPMC in Pittsburgh, and my research interests are in mostly molecular markers, but we look at a lot of extensive surgery for thyroid cancer and thyroid nodules as well. Thanks so much.
Okay, thank you guys all once again.
Thank you for all, like Vikram said, thank you for participating, and we're going to begin the questions now. We would like to remind the audience that you can ask questions via the comment section in the Facebook live stream. Please keep your questions as broad as possible, as we cannot answer questions very specific to any individual case.
Great, so we'll just go ahead and start off with the questions. We're going to start with a pretty basic question, but an important one, which is, what are the different types of thyroid cancer, and approximately, how common are they, or how common is thyroid cancer? So I'll start with Dr. Leung.
Hello, everyone. So thyroid cancer is climbing to be one of the more common cancers in the United States, but thankfully there are maybe about 52,000 new cases diagnosed every year. The vast majority is something called papillary thyroid cancer, which is falling under the umbrella of what we call differentiated thyroid cancer. And thankfully, the prognosis of most of these types of very common papillary thyroid cancers is quite good. And then the remainder of the thyroid cancers fall into more smaller categories. So there's second in line would be something called follicular thyroid cancer, and then very, very rarely medullary thyroid cancer, anaplastic thyroid cancer. These are maybe some of the more rare terms.
Great. So to follow up that question, how is thyroid cancer unique in comparison to other cancers? Dr. Harari, would you like to give that a shot, please?
Sure. Thyroid cancer has been increasing in incidence, as Dr. Leung has just mentioned. So it's kind of has gotten an exponential increase over the last 3 decades. Now it's started to flatten out, but that's making it a little bit more unique in terms of its trajectory. However, it's most of the subtypes of thyroid cancer are treatable. So that's somewhat of a relief, and the lifespan, the longevity of a patient that's been diagnosed with thyroid cancer is much longer than a lot of the other more common types of cancers like breast cancer and lung cancer. It's kind of, I'm not sure where this question is going, but in terms of its uniqueness, its location is in the neck. It's treated with a radioactive pill, which is unique to it. Some of the subtypes, the papillary thyroid cancer and the well-differentiated types are treated with that, as opposed to the more traditional chemotherapy agents that other cancers have been treated with. So there are a lot more, but I'll stop at that.
Great. So this question, seems simple, but probably is a lot more complicated, and especially gets more complicated, I feel like, with every year. But the question is, what are the treatment options for thyroid cancer? And I will go ahead and direct that to Dr. Lubitz.
Thank you, Vikram. So that has evolved quite a bit over, as you well know, it has evolved quite a bit over the past few years, and will continue to. So when we're counseling patients about once they're diagnosed with thyroid cancer, and we'll just say it's a papillary thyroid carcinoma or cancer, at least for the purposes of this, because I think it's the most common, as Angela said. And so the options are do nothing. Something we called active surveillance, which is something new on the front, and at least in the United States. The other option is to have surgery, and different extent of surgery. So depending on the size of the tumor and different characteristics and interaction with the patient about what they would like, and depending on what the tumor biology is following surgery, the pathology that we find out, then there potentially can be other things that Avital was discussing, potentially giving radioactive iodine afterwards, which is being used less and less. But I think overall the trend has been to do sort of the least aggressive therapy, knowing that most patients do well regardless of our treatments. And so again, it depends on the size of the tumor and other characteristics and risk factors, potentially mutational factors, but all of those things are on the table. And that's why it's important for us to really have a detailed discussion with our patients and those of you who are listening about quality of life measures and what you're comfortable with as well. So it's definitely an interactive decision, fortunately, because most people do well.
Thank you for that. We actually do have an audience question related to one of our previous topics that I will direct to Dr. Harari, as it is an interest of hers, which is, can you address the reason the thyroid cancer or the incidence or diagnosis of thyroid cancer has been, reported as being increasing over the last 3 decades?
Sure. This is multifactorial. And one of the reasons that has been thrown out there is that there have been incidental nodules and cancers picked up through other imaging for other modalities. So if somebody is getting a MRI of their neck and then they find a nodule in there, then they pick up a small thyroid cancer. That has been one part of what we think is in the rise of the incidence of thyroid cancer. there are, and that's a subset of physicians that feel like that is maybe the only explanation. But I am in another subset of physicians that also feel that there's an environmental component of this. There have always, and the reason is there have also been studies that show that there are large thyroid cancers, more advanced thyroid cancers that are increasing in incidence as well. And I think that, you know, I've done research showing that in certain parts of the country, there are more advanced cancers than other parts of the country. And why is this the case? So I believe it's multifactorial. Yes, we're picking up smaller cancers, but I feel like there's an alternative explanation or an additive rather explanation that can also explain the rise in the thyroid cancer rates. Recently, the thyroid cancer rates have sort of flattened, and some of that has to do with one of the types of thyroid cancers has been downgraded, so that also can kind of flatten your curve because previously it was labeled as a cancer. But for the most part, if you look at what our incidence is now versus 30 years ago, it's a drastic difference.
Great, thank you for that extensive answer. That was wonderful. Another question that a lot of patients have is the role of molecular markers, you know, their strengths, their limitations. So if a patient comes into your office, what do you usually tell them about these strengths and limitations? I'm going to direct this question to Dr. Yip.
It's complicated. So we use molecular markers mostly right now for diagnosis. So when we get people with thyroid nodules, we get biopsies, and sometimes those biopsies come back and are inconclusive, meaning that they're not benign and they're not malignant, but they're somewhere in sort of the gray zone. And the risk of cancer for those nodules in that gray zone can range anywhere from 5 to 15%, all the way up to 50 to 70%. And so in years past, we used to do surgery for all those indeterminate or inconclusive biopsies, but we were doing a lot of unnecessary surgeries for people who ended up having benign nodules. And so that's why the molecular markers were initially developed. And that's how we typically use them now, is to figure out whether or not somebody needs surgery to eventually sort out whether or not they have cancer. There's certainly a lot of research at looking at molecular markers for other aspects of thyroid cancer care, whether or not it helps us figure out who has more aggressive cancers versus less aggressive cancers, whether people may benefit from more aggressive treatment like radioactive iodine, and certainly in a very, very small percentage of patients who have very aggressive cancers that don't respond to iodine, there are some specific molecular markers that have targeted therapies where we can actually figure out what kind of chemotherapy may work best for those patients. But those are more unusual cases, and so I think right now, for most patients, the utility of molecular markers is really in the initial preoperative stage before we even figure out that they have cancer.
Great, thank you very much. We actually have a question from the Facebook live feed. Can papillary cancer be inherited from a mother who's had papillary cancer? Dr. Patel, would you like to give that a shot?
Yeah, sure. So you know, and generally when we think of thyroid cancers that are inherited, we're not really talking about papillary thyroid cancer for the most part. There are other types of thyroid cancer, specifically medullary thyroid cancer, that seems to be more what we call, you know, of an inherited type of cancer. Having said that, you know, yes, I mean, papillary thyroid cancers, we do have families in whom papillary thyroid cancers can be inherited. Normally, we look at least up to 3 people within the first generation of the family that have papillary cancer. We can say it's probably some form of a genetic inheritable papillary cancer. But if it's just one person in your family that happens to have it, and you also happen to have it, most likely it's just sporadic. But if you have multiple members of your family that have it, then there is some evidence to show that it could be genetic.
Can I jump in? You said we can all jump in, right?
Yeah.
Yes.
But I think what's really important, that was a great summary, Kepal, but sorry, Dr. Patel, that I think it's also important to note that if it is with papillary thyroid carcinoma, that the prognosis is still excellent, even if it is inherited. I think that's really important for the audience to hear.
Oh, great, thank you. Yes, of course, at any time, please feel free to add in or bounce off of each other. So this next question is a popular one, and actually I'm going to cycle this back to Dr. Patel because he's near Sloan Kettering and probably interacts with a lot of patients that have this question. So who is a candidate for active surveillance of a thyroid cancer?
So active surveillance is something that's actually, we think of it as something that's kind of recent that we've been doing in this country, but it's been going on for over a decade in other parts of the world. And it's actually a very proven technique as far as, following patients who have small papillary cancers is really what we're looking at. So traditionally it was patients who had papillary cancers 1 centimeter or less that were kind of candidates for active surveillance, who had no other comorbidities, who were actually okay with having their cancer followed. But nowadays we've kind of started pushing the limits a little bit. And I know at Sloan Kettering, they've pushed up to 1.5 centimeters papillary thyroid cancers, where, if you have a patient who has a small cancer who otherwise is, asymptomatic and feels well, then they will consider active surveillance in those patients. Now, there are a lot of other factors that go into this. The location of the nodule is very important. If you have a cancer that's kind of in an area that's concerning, somewhere maybe, next to your esophagus or your trachea, where your vocal cord nerve could be potentially involved if the cancer grows. And sometimes we'll say, hey, even though your cancer is small, we don't like the position of the cancer. We don't like where it is. We would probably not, recommend active surveillance for that patient. But other than that, active surveillance is usually for small papillary thyroid cancers.
Can I just add to that a little? So I just wanted to say that I completely agree. There are some other subsets of patients that you might consider moving forward with surgical removal if they have, positive lymph nodes, obviously, the more aggressive subtype perhaps. Contralateral thyroid nodules that may or may not, look like they might be cancers. And then just taking into account, how old the patient is, how long the surveillance will be. I think some of the studies have shown that there's an increased rate of growth or even lymph node metastases in the younger, especially male patients. So those types of people, maybe where you live soon, perhaps will know if there's certain characteristics or exposures that you've had that might put you at greater risk for more advanced disease. But I think in general, we always offer this to the patients that have what Dr. Patel has described. But it's just understanding that you need to have, close follow-up and ultrasonography.
So the next question is, what decisions influence the extent of surgery? Whether you take out half the thyroid, take out the entire thyroid, take out the things behind the thyroid, the lymph nodes, or if you take out the lymph nodes on the side of the neck. So what really, what's influencing your decision when you talk with your patients? I'm going to direct this question to Dr. Lubitz.
I'd be happy to answer that question. So I'll use Dr. Yip's. It's complicated, but I think again, the reason when decisions are complicated is because the outcomes are similar regardless of our decision. So it becomes an interaction with your patient about various factors. So the first thing is discussing in the way I practice, I should say, is what Dr. Harari was talking about, is that maybe there are nodules in the contralateral lip. So if you have a tumor on one side, but the other side has a bunch of benign nodules, because many people have benign nodules as well as, which is distinct from other organs, that there are many more benign nodules than malignant nodules. The discussion about where the tumor is located, which is what Dr. Patel was talking about on both sides, whether or not a patient is really against thyroid hormone replacements, because when you take out the entire thyroid, I'm sure we're going to talk about this later in the discussion, when you take out the whole thyroid, you 100% of the time need to take thyroid hormone replacement. And there is a debate about whether or not, I tell my patients, oh, it's exactly like the hormone that is made in your body, but there are a lot of patients that come back to me and say it's just not the same, even if their levels are perfect. Versus, someone who doesn't want to ever think about the other half of their thyroid, making that decision about, I don't ever want to think about having another thyroid surgery. So there are lots of things that go into it. The lymph nodes, taking out the lymph nodes in the area, so we call this area the central lymph node dissection. You may read about. It's sometimes called level 6. If the lymph nodes, and this has changed over time with the various ATA and AAES guidelines. Back in a couple of guidelines ago, we were taking out the lymph nodes in that area on every patient who had a papillary thyroid carcinoma and taking out their whole thyroid. And again, like I said before, we're evolving to being less aggressive when we know that the outcomes are unchanged by doing that. If there is a lymph node, so there's a little nodules around the thyroid gland, that all of us have, but sometimes they can be involved with cancer, that when you see them, when you're in the operating room or on our ultrasound that almost all of, I assume most everyone on the call does prior to surgery, if you see lymph nodes that appear to be involved, that's a different category. So if there's a lymph node that either you biopsy and is involved, or you see looks really abnormal in an ultrasound, and most of us are pretty good at looking at one and realizing it looks abnormal, then you take out the entire group of lymph nodes. And we've learned over time that when you do what's called a compartmental dissection, that the recurrence risk is less in that area, meaning if you take out all of the lymph nodes in the area, you have a better chance of not ever having to go back in there. That was a long-winded answer, I apologize. Anyone else want to jump in and add anything?
Yeah, I actually was going to say, no, thank you. That is a very complicated question. I think we can all agree that that's like a very nuanced and individualized, personal, tailored discussion with every single patient that we see.
Yeah.
Yeah, I'm going to add, sort of jump off on that as well. It's a little bit of what Dr. Lubitz had said earlier, is that the patients with thyroid cancer often live for a very long time, which is good. And so a lot of the decision making up front ultimately has to take a lot of these patient-related factors into consideration. So a very common question is, what would you do? You know, patients ask me, well, would you take out the half of the whole thing? And it's so difficult because what's important to me is so different than what's important to the person sitting across from me. And so it takes a lot of time to go through all these options. And I know that these decisions are hard, and we do try to guide people in one way or the other as best as we can from a clinical and cancer standpoint. But it does take some consideration for what's important to the patient. So.
Yeah, I mean, I think just to add a little bit to that, I think one thing I always try to get across to my patients is that there's no wrong answer here. Sometimes the patients are looking for the right answer. I'm like, you have two right answers. We just got to figure out what's right for you. And I think that's important for them to realize, because sometimes people often walk away saying, well, what's the right thing to do? I mean, if I do that, take out my entire gland or just half my gland? And I tell them they're both right answers. So I think that's a good message to kind of get across.
So do you think the type of cancer will change how much of the thyroid you're going to take out, whether it's papillary, medullary, or anaplastic, or follicular thyroid cancer?
Oh, yes, I didn't address that. I was just talking about papillary. I apologize. Yeah, so the whole discussion we just had is really isolated to the well-differentiated thyroid cancers. Medullary thyroid cancer is a different bird, and medullary thyroid carcinoma, everyone gets a total thyroidectomy and everyone gets those lymph nodes taken out. And in Europe, they do bilateral lateral necks. I don't know if anyone else on the call does that. So that's a different bird. And the reason why we're more aggressive with our surgery is because it's shown to be really important in terms of curing the patient up front. And that's slightly different than papillary, where we have other adjuvant therapies that are really effective, including radioactive iodine. And anaplastic thyroid carcinoma, I think we're a little bit out of the scope of this conversation, but surgery may or may not be an option in those patients, and definitely need to have a multidisciplinary team to discuss various options for treatment for those patients. They're very rare, but it's a very aggressive tumor. And again, you want to have an endocrinologist, a medical oncologist, radiation oncologist all weigh in on what the best therapy is for those patients.
Great, thank you. To sort of branch off of that, for Dr. Yip, if you want to comment on sort of the role of molecular markers, or even sort of the actual gene expression classifiers and those gene expression profiles, where we're getting an actual list of what genes are expressed, and how you and your experience with that as far as helping influence your discussion with patients about the extent of surgery.
Yeah, that's an area definitely of active research. I mean, I think that we have a little bit of a broad understanding that some mutations are associated with what we would consider low-risk cancers, which tend to be encapsulated, usually don't go to lymph nodes, tend to have a very excellent prognosis after surgery. There's another class of mutations that we would consider more intermediate risk, which may have a little bit of a higher risk of lymph node metastases, maybe a little bit of a higher risk of recurrence. And there's definitely a subset of cancers that are what we definitely consider high risk, with a higher risk of distant metastases, and these cancers may not respond quite so well to radioactive iodine treatment. And so I think there's areas of research in each one of these areas. I think the missing piece of that puzzle is whether or not, if we find these mutations before surgery and alter what we do at the time of surgery, even after surgery, will that ultimately change the course of that patient's sort of outcome, and that we don't know. But certainly there are trials, and people can go to clinicaltrials.gov to look at some of those trials that are ongoing.
Great, thank you so much. So our next question, will break up into multiple components, but it's basically dealing with thyroid surgery and basically describing thyroid surgery. So we'll start with Dr. Harari, if you want to kind of describe the conventional approach to a thyroid operation, whether it be half of the thyroid or the whole thyroid.
Conventional, so via the neck.
Right. Oh, sorry. Yeah. So transcervical conventional open thyroidectomy.
Okay. So the conventional approach has also changed from a few decades ago, where surgeons used to approach it with very large, low incisions, and more and more we're making our incisions smaller, less noticeable, sometimes in a crease. Depending on what you're presenting with, how big the cancer is, if you have lymph nodes involved, will determine how big your scar will be. And in terms of the approach, what exactly do you want to know, Vic?
Kind of just like when you consent a patient about thyroidectomy, kind of explaining
okay.
to them the steps and the risks and what they can expect as far as recovery.
Okay. So, well, as Dr. Lubitz sort of covered, ahead of time we'll decide, what kind of surgery is appropriate for the patient, what they want, lobectomy, total thyroidectomy, lymph node dissections. And then what I'll typically do is sit down and really just draw my patients a picture of this is what your thyroid looks like, and this is what it looks like on the ultrasound. Sometimes I'll show them the ultrasound pictures. And then they'll kind of get a visual understanding of what it looks like inside the neck. And then I'll start talking to them about what it means to remove it and what are the structures that the thyroid is actually attached to and why there are certain risks that are involved with thyroidectomy. And those risks can range from injury or stunning of the recurrent laryngeal nerve, which is a nerve that moves the vocal cords and can cause hoarseness if it doesn't function normally. This can be a temporary problem in most people, but sometimes a permanent problem. Sometimes a cancer is completely surrounding the nerve and may have to be excised with the cancer. So that's a serious discussion we have. We have a discussion about the parathyroid glands. Those are little glands that are sitting around the thyroid that regulate the calcium levels. And so if you're doing a total thyroidectomy and you put all of these glands at risk, they could sometimes also be stunned from dissection. They have microscopic blood vessels that all of us are very careful to try and preserve, but sometimes they don't function well. And if that happens, the calcium levels can drop and patients will require multiple calcium supplements after the surgery. Again, this is usually a temporary problem, but can be a permanent problem. We talk about the bleeding risk. There's a small risk of bleeding after surgery. So sometimes, depending on how extensive the surgery is, many of my patients will leave same day, but I'll keep them for anywhere from 4 to 6 hours after their surgery to make sure there's no swelling in the neck. But sometimes we have to keep them overnight for calcium reasons or issues with their nerve. And so in terms of the bleeding risk, it's usually going to happen in the first 4 to 6 hours. And so we carefully monitor you for that. When you go out to the lateral neck and you start to do dissections of the lateral neck, I'm sure some of us have the same approach. I typically just move my scar over to the side and kind of dissect up and down and get all the lymph nodes from above and below that area in a compartmental dissection, as Dr. Lubitz had previously stated. This area has other, anatomy that you have to be aware of. The carotid artery and the internal jugular vein are large vessels that are in the neck. There's also the vagus nerve, which actually feeds the recurrent laryngeal nerve. So in theory, you could lose your voice from injury to the vagus nerve. There's a nerve called the phrenic nerve, goes down to your diaphragm. There are a couple nerves here that go to your tongue and to your shoulder. So you might have some issues with that dissection. And then specifically on the left side, there's a duct called the thoracic duct. This is a duct that collects fluid from all over the body and kind of dumps it back into your vascular system from the tissues in your body. And if that gets injured, you could have a slow swelling that's milky, and you have to go have a drain and all sorts of things to correct for that. So, depending on what the patient presents with, we'll discuss certain anatomical considerations and risk factors.
Thank you so much for that. Very good and thorough explanation of delicate operations, but this is something that we talk about with our patients all the time. I just want to underscore, with thyroid surgery, we, as people who do thyroid surgery all of the time, it sounds like a lot of nerves and vessels and steps and scary things, but generally speaking, we would all agree that thyroid surgery is very safe, in most patients. But moving kind of off of that and branching to another topic that is commonly asked is, more new approaches or novel approaches to thyroid surgery. And Dr. Kepal, Patel, would you want to kind of discuss some of the different newer approaches that have emerged in recent years?
So we have a whole new subset of procedures that have kind of evolved over the last couple of years, and we kind of lump them together as remote access procedures. And really, full disclosure, I don't do them, so I'm going to be speaking about something that I personally don't do. So I'll just let you guys know. But having said that, they really, in select places with people who have good experience in doing these procedures, they've been proven to be extremely safe. One of the approaches that was initially designed a couple of years ago was removal of the thyroid gland through your axilla or your armpit. They put in small little scopes. They mobilize the gland in your neck, and they kind of remove it through your armpit. And so the real advantage to these remote access procedures is really to limit the scar that you have in your neck. Other than that, there's no other real major advantage other than really just kind of a cosmetic advantage. But first, for the right person and with the right surgeon, these are really safe procedures. And more recently, the transoral approach has really kind of started to kind of take off a little bit, and that's really removing. It sounds kind of maybe doesn't sound natural, but removing the thyroid gland through your mouth and basically making an incision on the inside of your lip. And basically tracking it down to your thyroid gland and to your neck. And anatomically, it kind of makes sense. You can do it. Once again, it's a relatively safe procedure in the right hands. If this is something that a patient is interested in, I would highly recommend for them to seek out an individual or a surgeon who does this pretty frequently and routinely. And there are a few in this country that do that pretty frequently and routinely. So I think that's really the take-home message with these remote access procedures. They're out there, they exist, they're safe in the right hands. The basic advantage is cosmetic to basically minimize basically no scar in the neck.
Oh, great, thank you. And so the next question I'm going to ask related to surgery is when it comes to, we'll talk about just referring back to conventional thyroidectomy with the neck scar. I'll address this to Dr. Lubitz. We talked, Dr. Harari mentioned the potential complications that can occur. And so what are the types of things that can be done during an operation, either perioperatively or intraoperatively, to help avoid or mitigate these risks or these complications?
Gave me the easy one, huh? We're still learning every day. No, the most important thing I think is what Dr. Patel just said, is having experience, right? So there's pretty good data out there that the surgeon needs to do a lot of operations that are very specific and focused on doing thyroid operations. We just discussed a lot of nerves and important structures that are around there, and if you're doing that every day and looking at those structures, it's really important. So volume of your surgeon is very important. I have patients ask me all the time, and I'm more than willing to answer, how many cases do you do a year? It's a reasonable thing to ask your surgeon. So that's the first thing, is being prepared and being well trained. The second thing is when you're in the operating room, and this is a little controversial, I happen to use something called a nerve monitor. This is specifically in reference to that nerve that Dr. Harari was talking about, the recurrent laryngeal nerve, which is the nerve to the vocal cords. You have one on each side. And so that is not helpful in terms of necessarily avoiding injury. You need to know where the nerve is anatomically. But it does help in terms of when we talked about whether or not you do both sides. It helps me in terms of deciding when it looks perfectly intact, it may still be stunned and still not functioning, in terms of whether or not to go to the opposite side. So that's one thing that's helpful for me. Not everyone uses it, and there isn't any particular evidence saying that you need to use it, although most people in Europe and I think in the United States are now using it. It doesn't help prevent injury, but I think it really helps with decision making. In terms of the parathyroid glands that we were talking about, and those regulate, they're 4 lentil-sized and shaped organs which are attached to the thyroid, which regulate the calcium in your body. And they're very temperamental, especially when you take I call it the bed out of there, and you try to protect those parathyroids, even if they're in place and you're not removed during surgery inadvertently. They can still lose their they fall asleep, they get stunned, and they lose their blood supply. So some people, many people, I've started doing this now, check that hormone level immediately following surgery. So PTH is a hormone that you can check in the operating room. We're fortunate that those little glands, that number fluctuates very quickly. So if you check that in the operating room, it can help you decide whether or not or how much to give in terms of giving additive calcium to those patients, and potentially something like an activated form of vitamin D to help you absorb the calcium so that you don't have the symptoms. The symptoms of hypocalcemia are numbness and tingling around the mouth or fingertips. It feels like you like hit your funny bone, and it feels, I'm acting like I know what it sounds like or what it feels like, which I personally haven't felt like, so I apologize, but my patients have said that's what it feels like. And you treat that with giving supplemental calcium and then sometimes vitamin D. Did I answer all those questions? But the other thing that's important, obviously, with the scar, if that's considered a complication, is to make sure it's in a natural skin crease. I like to make sure it's symmetrical and as small as you can by getting the tumor out and the thyroid out safely. And then with the hematoma, thinking about whether someone's on a blood thinner or not, and in terms of whether or not to admit them. Dr. Harari mentioned this, maybe someone's at a higher risk of having that swelling in their neck following surgery, and you may consider keeping that patient in the hospital overnight just to keep an eye on them.
Oh, great, thank you very much.
So, after having thyroid surgery, one of the main questions for patients is how are we going to follow up to find if it comes back? And so everyone has a little bit of a different schedule as follow-up. What do you generally tell your patients, Dr. Leung, about looking for cancer coming back, or when to follow up, or what to worry about?
Yeah, so that's a great question. Many, the vast majority of folks do well after their initial treatment of thyroid surgery, especially if it's done in the hands of an experienced surgeon. But there's always the chance of either persistence of the disease, meaning there's a little bit remaining, or recurrence of the disease, meaning it comes back. And so how do we monitor and how do we find out that it might be back? It's a combination of blood tests. There's something called thyroglobulin, which is a protein made by the thyroid gland. And of course, you can imagine if the entire thyroid gland is removed, that protein should be essentially zero. That protein is made by both normal thyroid cells as well as cancerous thyroid cells. But if you have no thyroid remaining, any sort of rise in that blood test, that thyroglobulin represents perhaps return of the cancer. So that's one part. And then secondly, to confirm, we also do imaging. And so there's different types of imaging, the thyroid ultrasound or neck ultrasound after you've had no thyroid. Neck ultrasound is sort of the best modality because it lets us look at really tiny spaces really well in the hands of a good ultrasonographer. Many of us do our own ultrasounds in the clinic. You can sort of see something suspicious and then do the blood test to confirm. I think different people just have different styles of how often you do these things, the blood tests and then the imaging with the ultrasound. I personally do sort of an every 6 month schedule, maybe a little bit more frequently, maybe 5 months if the thyroid cancer is really aggressive. And then thereafter, every 6 months for the first maybe 2 years. And if it's really boring and stable, we don't see anything, then maybe once a year after that. But I think it's important for folks to still continue to come back and see their physician, either their endocrinologist or their surgeon or both, just to make sure, just because thyroid cancer, worst case scenario, very, very rare, can come back many years later.
Great. Do you want to comment also on maybe medullary thyroid cancer as well, how you followed those patients?
Sure. So as I said earlier, thankfully, medullary thyroid cancer is much more rare. But when it happens, we kind of use the same thing. We use a combination of blood tests and imaging, but this time the blood test is different. So this time The medullary thyroid cancer cells, if they were to come back, would be making something called calcitonin, which is measured in the blood. Sometimes people also use a blood test called CEA, a little bit less specific, but you can use the two together to detect any recurrence or persistence of the medullary thyroid cancer. The imaging for medullary thyroid cancer is a little bit different. Certainly a neck ultrasound is still the best, just because we can see the little spaces. But when the calcitonin blood test goes up, specifically over 150, this is when we need to get a little bit more serious and look at more extensive structures around this. So something called a CAT scan would be needed.
Great. Thank you very much for that extensive answer. So when you do talk to your patients, Dr. Leung, and they have to choose a surgeon, how do you direct them?
Well, I think what Dr. Lubitz said was so correct. I think it's perfectly fine. I often see patients first because they're coming to see me maybe from their primary care doctor who found a thyroid nodule incidentally, either on palpation of their neck at their annual exam, or maybe they got a neck MRI for neck pain and they found a thyroid nodule. So I'll get to see them first many times. And if indeed we confirm a thyroid cancer and it's time to think about surgery, thankfully I work with a large group. Dr. Harari is one of them, and they're all very experienced doing high volume thyroid surgeries. But if it indeed was perhaps a patient who's referred from the outside, or is living further away and they don't have local access to a thyroid surgeon, I encourage exactly what Dr. Lubitz said. I say, maybe ask them exactly how big their volume is per year, what is their complication rate, specifically complications Dr. Harari mentioned about the voice hoarseness, and then damage of the parathyroid glands leading to low calcium levels. Those are all certainly just great questions to probe your surgeon, and find someone who feels right and answers all those questions to what you're comfortable with.
I'll jump off of that just really quick to say that we have a directory for the American Association of Endocrine Surgeons for fully trained endocrine surgeons that are high volume surgeons. So anywhere you live in the country, you can look that up. And if you're elsewhere in the world, the International Association of Endocrine Surgeons also has a list of very capable and very surgeons. So that's another place that you can look, and we can show you the links to those two places if you'd like.
I actually wanted to ask Dr. Leung another question. So we see this a lot, and I'm sure it's happened to many patients, when we take out a lobe, it turns out to be cancer. And so I was wondering, we rely a lot on our endocrinologists to give us some input as to whether or not we need to go back in and do a completion. And so I was wondering if you could talk a little bit more about what your criteria are for going back in and doing a second operation.
Yeah, so we were talking a lot earlier about just taking out half the thyroid, maybe one side, because it seems to be low risk, and the other side doesn't seem to be affected. It's very clean looking on our ultrasound. But indeed, sometimes the thyroid cancer that comes out from that surgery maybe is a little bit bigger than what we saw on the ultrasound, or it has more aggressive features underneath the microscope. Something sort of, a little bit more unusual than the garden variety papillary thyroid cancer. So there's a couple of things that would prompt us to recommend going back to the surgeon, and, usually very quick, when the scar is still fresh, within a week or so, to remove the other side. And so those would be cancers that are on the larger side. And so we're talking about closer toward 4 centimeters, and definitely those above 4 centimeters. Or, exactly what I said, underneath the microscope, it's got just some more aggressive features, what we call perhaps invasion into the blood vessels, into the local fat or the muscles. If there are surprise lymph nodes that are removed during surgery and they happen to have a little bit of the thyroid cancer themselves, that would prompt me also to recommend completion thyroidectomy. Thanks so much.
If I could just add a little bit to that also, the way I like to think of it, at least, is that if we did a lobectomy or a partial thyroidectomy, and then afterwards, if I feel that the patient would benefit from closer surveillance of radioactive iodine, I think those were kind of two things that would kind of lead me to also say, this patient's probably going to require a completion thyroidectomy. It'll facilitate giving the radioactive iodine or closer surveillance with thyroid globulin measurements, et cetera. So I think that leads to exactly what Dr. Leung was saying. It's basically you have more aggressive features and makes you more worried. So you're going to want to do more surgery at that point to kind of limit the recurrence. I mean, I think the one thing to remember is that the prognosis for most of these patients still remains excellent. It's really limiting, potential recurrence and potentially, improving their quality of life, but their overall prognosis still remains excellent.
And I think that's just a great point, Dr. Patel, to clarify. We can't use the other therapy that sometimes follows thyroid surgery called radioactive iodine. We can't do that unless the entire thyroid gland is removed. So it's not one reason to, prompt us to do the whole thyroid gland removal. But indeed, if radioactive iodine would be beneficial, then we would certainly do the completion.
Dr. Leung, when is radioactive iodine beneficial or not? I think that would be really helpful for the audience.
Yeah, I use the American Thyroid Association risk categories in helping me decide and counsel patients when radioactive iodine would be beneficial. So first of all, radioactive iodine, just to very briefly summarize, it's a dose of radiation, not coming from the outside like you might expect for other types of cancer, but it's a pill that person would swallow, and that pill contains the radiation that over the course of many months, 6, 7, 8, 9 months, slowly kills sort of the remaining thyroid cells that might be in the local neck or even elsewhere in the body. So when do we want to basically get rid of every single little thyroid cell that might be there is the question, right? Using radioactive iodine. So it's a sort of a no-brainer if the disease is very aggressive, what we call ATA, American Thyroid Association, high risk categories. So either very large cancers or very aggressive features, things of that sort, we certainly would give it. There's differing opinions of how much, but yes, the answer would be certainly we give it. Now we're starting to move for low risk categories, things that might be, just a little tiny cancer that doesn't involve any lymph nodes, it's not invading anything, none of high risk features. We probably would reserve not using radioactive iodine anymore. And that's a little bit of a departure from what we used to do in years past, and not even that so long ago. So there is a sort of a general movement to now fully more understand that these very low risk thyroid cancers don't really benefit from this additional treatment. So it's what Dr. Lubitz is, I think, hinting at is in that middle gray area, it's a little bit more unclear because there are a lot of people sort of on the fence, right on the border of having a little bit of aggressive features, maybe the size is bordering on the size of being big. And this is where I think it's individualized. I have a really long conversation with my patients going, talking about the pros and the cons and what to expect. There's isolation precautions that one must adhere to. There's potential risks long-term as well as short-term of taking the radioactive iodine. And then if we don't do it, then, there's always sort of this perhaps it's anxiety that a person might have little microscopic remaining cells, and is that sort of not worth the risk to this particular person because the anxiety level would be so high that, that it would not be worth it. So I think it's an individualized decision, just to briefly summarize.
So, sometimes, Dr. Leung, endocrinologists give extra thyroid hormone. Who do you typically give the extra thyroid hormone to try to prevent their cancer from coming back?
Yeah, so now we're after the thyroid surgery, and either the patient got radioactive iodine or not, but there's two jobs of the thyroid hormone. One is to replace the tank, right? A person needs to have a full tank of gas to go, and if they have no thyroid hormone, they certainly need some. But the second job of thyroid hormone is to kind of keep the cancer away. And so whether or not we overfill the tank and basically give you a little bit more ammunition to keep the thyroid cancer away, I think depends on what we just said, the aggressiveness of the thyroid cancer, how likely we think it might be coming back, and those sorts of thoughts. And then, filling the tank too much in older folks might not be worth it because it's a risk factor for heart arrhythmias, irregular heart rhythms, as well as bone loss. So it kind of needs to be weighed into perspective of who the person is.
So I'm going to pick it up from here to actually include some of the patient questions that are sort of related to TSH dosing suppression. You kind of touched on it a little bit here. So one of the audience members asked, are there any studies looking at long-term use of thyroid hormone replacement? So you kind of talked a little bit about, obviously if we give too much thyroid hormone, this could potentially, have a negative effect on the bones, and potentially also, cause problems with your heart. But a specific question was talking about, and this again, go to Dr. Leung, about the merit of the different types of thyroid hormone replacement, including, generic versus brand name, and then do you feel, that there's any sort of patient criteria where you might choose, one over the other, whether that be age or, even, postmenopausal versus perimenopausal, et cetera.
Great. Thanks so much for the question. I know that this is a complex topic, and in the office, I spend a lot more time in going over this, but let me maybe briefly address this question. So let's say that we have decided the person needs a little bit of thyroid hormone to either fill up the tank or keep the thyroid cancer away. There's sort of two big types of thyroid hormone, meaning where they came from. One is synthetic, meaning it's artificially made in the lab, and the other is desiccated thyroid extract, meaning it's animal-derived thyroid hormone taken from a pig or cow, or usually both. And so between the two of them, then they're further separated into the type of thyroid hormone. So in our thyroid gland, before it was taken out, primarily makes T4, which is sort of what I term as the storage form of thyroid hormone. And then in the body, depending on what your body needs that day, that particular moment, what stress it's under, gets converted from that storage form of thyroid hormone, which is T4, into the active thyroid hormone, T3. And this is actually a beautiful thing in the human body because it knows how much to convert from that storage form into the active form, depending on where it is. So perhaps a patient is stressed and needs a little bit more in the brain today, needs a little bit more in the muscle because they're exercising, et cetera. It'll convert it differently. So historically, what has been deemed the safest is to prescribe a synthetic form of T4, that storage hormone, and really wait for the body to naturally convert what it needs to on a minute-to-minute basis in different areas of the body at different rates, just so that we don't overshoot. Because there are potential risks of having too much of that active thyroid hormone. So going back to the analogy of the car, I like cars, is too much of that active thyroid hormone is like pumping too much turbo gas into the car. What if the car doesn't really need it right now? Or what if the car is really old, like an older person? Stressing the heart, let's say, or stressing the bones to really just be in overdrive all the time is perhaps not so good. We don't really know how much is too much of that turbo gas, how much is too much of that T3. So I think traditionally endocrinologists have, tried to veer on the safe side of prescribing a weight-based dose of the thyroid hormone at T4 and waiting for the conversion to happen. Certainly you can recognize what Dr. Lubitz has referred to recently, that some patients, they don't feel right. Maybe they don't feel like they have that active thyroid hormone or enough of it in their body after the thyroid surgery. Unfortunately, our ways of measuring these levels in the blood are not perfect. It is sort of a snapshot at one time in the blood, and it doesn't really measure what's going on in each of the different tissues. It doesn't measure how much T3 is in the brain and the lungs and the kidneys and the muscles, etc. So it's really hard to try to use those like a one snapshot level in the blood to make this decision. But at the same time, I think we're sort of understanding and really recognizing that certainly folks don't feel the same. And I don't know what that means because, again, I've not had thyroid surgery myself, but somehow just something doesn't feel quite right. So I have a a pretty extensive conversation in the clinic with my patient to say, these are the pros and cons. These are the areas at which we don't fully understand yet, but there are certainly risks. And if you would like to do those, then there are certain formulas of how much of that turbo gas we should prescribe compared to the storage form of the thyroid hormone. So at least that's what I would recommend. I hope that helps.
Yes, very much so. Thank you. So now we're kind of coming near our conclusion. So we have a few audience questions that we would like to address sort of as we wrap up here. So the first one I'll direct to Dr. Patel. It's about a patient that kind of wants maybe us to discuss radioactive iodine resistance. So I think maybe a way to do that would maybe describe, how you would maybe talk to a patient about radioactive iodine, which we talked a little bit about as far as how we would use it as far as a treatment, but what does it mean if a patient has a radioactive iodine resistant cancer sort of on a basic science level and on a clinical level?
So, I mean, in general, most, where we talk about well-differentiated or differentiated thyroid cancers, they take up radioactive iodine very, very nicely. And that's why patients do well in general when they have well-differentiated or papillary thyroid carcinomas. We have a great treatment for these cancers, especially if they've spread somewhere and they get radioactive iodine. It is a huge problem when you have a more aggressive form of thyroid cancer, and usually there's more, undifferentiated or dedifferentiated cancers where they no longer are taking up the radioactive iodine. Usually the more aggressive tumors, pathology of them are different. They're poorly differentiated. They're, different variants, aggressive variants of papillary cancers. And over time, they stop taking up the iodine, and we don't really have great effective treatment for these patients sometimes if they have disease that's spread to other parts of the body and they're no longer taking up the iodine. At that point, we do sometimes, rely on our molecular profiling, our molecular markers to see if that tumor has a gene or a mutation that we can target and specifically give them some form of inhibitor. So we've used RAF inhibitors, MEK inhibitors for some of these really aggressive cancers to see if we can, slow down their growth. And sometimes actually by giving some of these inhibitors, we can actually make these tumors sensitive to iodine again. So that's also been a strategy that's been used by giving these more aggressive cancers some of these targeted treatments and then to try to reintroduce radioactive iodine sensitivity into these tumors. So, but thankfully these are extremely rare situations. Majority of patients do not have to deal with this, which is great. But in the rare situation when we do, these are definitely more complicated, scenarios.
So thank you very much.
Just add, Vikram, that although the question may have only been for the papillary and follicular and anaplastic, that medullary thyroid carcinomas are not responsive to radioactive iodine. That's because of the cell of origin. That's just something I don't know if whoever asked the question was referring to that.
No, definitely. Thank you. And so actually, because you're still on my screen, I'm going to direct this next question to you. And just an audience member wanted to know, is there any role for either or any active stem cell research or role for stem cell therapy as it pertains to thyroid cancers that you know of?
Is that for Kepal or for me?
Well, it was actually for you, Dr. Lubitz, but actually for anybody. This is open panelist discussion.
Me neither. Yeah. I don't think so. Maybe Kepal would be. Does anyone else know? I don't believe so.
Not that I'm aware of, actually. Yeah. I'm not aware of any active stem cell research going on right now for thyroid cancer.
Great. And then the last question, it's a little broad, but we'll try to address it. I'm going to start with Dr. Leung. As far as audience want to know, sort of in your experience, how often do thyroid nodules change in size versus remain stable? So we'll start there. And then the next one, I guess I would reframe as, what would, maybe what size threshold or what sort of symptoms might a patient have or things that you might find clinically that may have you sort of talk to a patient about having a thyroid nodule removed?
So directed to me. Okay, so the first question again, really quick.
So kind of just generally speaking, all comers, how often do thyroid nodules actually change in size?
Oh, right. So first of all, this is a great statistic to remember. The thyroid nodules are incredibly common. How common are they? By the time a woman reaches postmenopausal age, so like 50, 55 years old, you have to become more likely to have a thyroid nodule than to not have a thyroid nodule. They're that common, especially in older women. So obviously these are all over the place. Everyone has one. You know, sometimes they're picked up by palpation or ultrasound or whatever, some sort of imaging. We usually just follow them with an ultrasound once every year or two, just to make sure they're stable. If they are concerning, like a thyroid cancer, they should grow more than 20% with every time that you look at it. And so that's when it would maybe prompt me to put a little needle into it and biopsy to make sure it's not a cancer. But anytime, even at the first time, if it's a large enough size, that's when we do biopsy it, because that's when we have a higher suspicion that it might be thyroid cancer. By the way, all comers, maybe about only 5 to 10% of all these really common thyroid nodules have a cancer hiding inside of them. So pretty rare. But what size would we bite the bullet and, you know, go ahead and do the biopsy with the first time that we meet you? It really is a combination of the size and what it looks like, colors, you know, where it is located in the thyroid gland, et cetera, on our ultrasound. So find a person who knows how to really do a good ultrasound and can follow the guidelines in classifying what type of thyroid nodule you have and what that risk would translate to. But generally it would be between 1 to 1.5 centimeters, or sometimes even more, at which we would biopsy the thyroid nodule.
And I would kind of just to add to that, is I would strongly encourage any patient to, if they do have an endocrinologist or they do follow with a surgeon that does do their own in-office ultrasound, to stay consistent with that individual, because they're more likely to measure a nodule in the same way each time you see them, and there will be less variability between the ultrasound reports, because we all see a lot of patients that that have ultrasounds kind of at different locations, and then they report that there has been some change in size, but there may not have been, and that's just as a result of difference in technique and difference in the person who did the ultrasound, the person who read the ultrasound, or even just the ultrasound machine. So I think that was our last question. So Dhaval and I would like to thank all of our panelists again for participating. And definitely thank you to all of the audience members for listening and for viewing, as well as providing your questions. And also, again, a huge thanks to the American Thyroid Association and to ThyCa for partnering with us. Of course, again, you know, if anybody's interested in learning a little bit more about surgery or thyroid cancer, they can always go to the American Thyroid Association webpage, as well as the American Association of Endocrine Surgery, which is AAES, or endocrinesurgery.org, for more information.